نور يا عمر. نور يا عمر ماشي كمان.
الو.
ايوه يا عمر.
دكتور ناصر، اهلا وسهلا.
طيب خلاص كده فتحنا اهو. مش
شداد فين؟ مش شايف شداد.
بنتكلم بقى لما تكتب عشان نعرف نلاقي بعض. يا عمر.
منورين يا شباب.
اهلا وسهلا.
منورين.
دكتور اسامه.
دكتور اسامه بيه، ازي
دكتور
الصحه؟
ناصر باشا.
مع سيادتك، عامل ايه؟
الحمد لله تمام. انت ما بتجيبش
اخبار
حد من
الساحل؟
الازهر يا عم اتكلم ولا يبقى مودريتور ولا يبقى اي حاجه ليه يا عم ناصر؟ مش دول حبايبك برضو يعني؟
انت رشح يا دكتور اسامه، واحنا ننفذ.
ارشح لك حد يعني، حاضر. ما انتوا عملتوا الجدول بتاع الشهر ده، يبقى اللي بعده ان شاء الله. ولو ان اللي بعده غالبا الامور هترجع تبقى كويسه، ونعمل اجتماعات
باذن
وش
الله.
وشك كده على طول.
ايوه، احسن احنا نسينا وشوش بعض كده.
لا عشان المناقشه تبقى سخنه اكتر يعني.
ايوه بالعكس، ده كده الواحد يقدر يتناقش ويضرب من بعيد لبعيد. مش كده؟
ايوه.
اخبار حضرتك إيه يا فندم؟
الحمد لله تمام تمام، ربنا يخليك.
واخبار الساحل ايه؟
اخر حلاوه الجو. الرطوبه زياده، بس احنا على البحر بقى ما انت عارف.
انا رحت من اسبوعين، لقيت الجو ولع برضه، مفيش فايده. مصر
لا
كلها ولعه.
لا ما جيتش عندنا ليه؟ يمكن ساحلكم غير ساحلنا يعني. تيجي
عايز
الساحل من
الواحد
غير ما
لازم يبقى
تمر
لازق
على
على
عمدة
البحر.
الساحل.
معلش مره لازم، بعد كده
ما
خلاص.
ينفعش الكلام ده.
طبعا طبعا طبعا. واخبار احمد ايه؟
تمام الحمد لله. ما هو شايل الشيله بقى.
والله انت يعني سيادتك بتصيف وسايبه بقى، ايه هو
لا
ايه؟
معاه بس يعني. هو واخد المين بالك يعني، انا كده
آه،
بتسند عليه كده، يعمل يا واد
كويس،
ود يا واد.
خليه عشان ينشف بقى، ينشف
عشان
بقى.
ينشف.
لا،
الله ينور
كويس كويس.
عليك.
كويس، لا ربنا يوفقه ان شاء الله.
ربنا
ربنا
يخليك يا
يوفقه ان
بيه.
شاء الله.
ولا اولادك كده.
الله يخلي حضرتك يا فندم، الله يخلي حضرتك. دكتور ناصر راح فين؟
موجود اهو.
دكتور ناصر، ده قافل المايك يا دكتور ناصر. دكتور
عامل له
ناصر،
انميوت، انا مش راضي.
بس هو الهوست، لازم هو اللي يعمل بنفسه.
هو المفروض خلاص الساعه 2 و22 ثانيه.
انا مستغرب، ما فيش شداد ما دخلش، وبنت شو برضو ما دخلش،
لا في
وفي
اخ. في
سو
اخ لابس عقال داخل اهو.
في البانل ليست. لا، دولت مش في البانل ليست، فمش هيسمعونا. البانل ليست هم اللي بيسمعوا بعض بس. دكتور ناصر،
هو قافل ميكروفونه ومش راضي يفتح ميكروفونه، فمش هيسمعك يا دكتور عمر.
حاجه غريبه، مستغرب دي.
هو موجود يعني، كون الصوره موجوده معناها موجود، بس مش راضي يفتح الميكروفون بتاعه.
بس كده هنتاخر. شداد وتشو و اسمه مسوق.
ان شاء الله هنبدا اللايف على اليوتيوب.
نعم.
هنبدا اللايف على اليوتيوب.
لا استنى، الدكتور ناصر لسه ما دخلش.
ماشي اوكي.
والناس السبيكرز والمودريتورز ما دخلوش. هل هم موجودين على طب اهو ده لو سمحت دخل مسارة اهو، مسارة موجودة اهو. ها؟ الو؟ الو؟ yourself. Dr. Shaddad, welcome. Unmute yourself, Dr. Shaddad.
Hello.
Dr. Qureshi, you hear me or not? دكتور ناصر. دكتور ناصر،
ايوه يا عمر.
انت سامعني؟ امال انا عمال اكلم الناس مش بيردوش ليه؟ عمال اقول لقريشي امنيت خلاص كده امنيت الشيخ ومسارة دكتور مسارة امنيتد
Yes,
شداد كبير دكتور شو is here. دكتور ناصر دكتور joined us now.
Hello.
Hello?
Hi. Hi, this is Dean.
Welcome, Dr. Chubin. Welcome.
Hi.
It's our great pleasure.
Great to see you. Yeah.
It's a great honor to invite you.
hmm Thank you.
Do you finish your surgery?
Yes, just finished. So
Okay,
today
okay.
I have 12 cases. Sorry, I'm
Great
late.
welcome. It's evening now or what?
Yes. It's 8 p.m.
10 p.m.
8.
I think this is your time to go to bed or what?
عمر
Yeah.
صوتي واضح؟
So now you can see my slides.
Yes.
عمر
ايوه دكتور ناصر.
الصوت بتاعي واضح؟
واضح كده واضح. كلهم كده موجودين خلاص. كلهم موجودين.
بروفيسور محمود قرشي is here.
دكتور قريشي.
Yes, I am here. I'm here watching you.
Welcome, Professor
How do you do?
Qurashi.
Welcome.
Professor Binzu, did you already arrive?
Yes, he's
Hello, Qurashi. Mr. Qurashi.
Yes, hello.
Hello.
Osama Al-Ghandour, how are you?
Hi.
Nice to see you.
Good
Nice
to see you
you.
here.
Uh-huh.
Very
So
well.
nice to see you too.
Oh, thank you.
How do you do, Qureshi?
Alhamdulillah, I'm good.
Muhammad Shaddad. Welcome, everybody.
And Dr. Musara is
thank
here
you,
also.
Nasser.
Welcome, Dr. Musara.
I have one of our
Thank
colleagues
you.
from,
Thank you very much.
his name is Professor Muhammad Helmi. He would like to introduce Professor Binzu. So Professor Qurashi will say his welcome speech, and then me,
Okay.
each one will take a few minutes, and then I will give the speech to the moderator. Professor Aaron Musara is here. Aaron, are you here?
Yes, he's
Yes,
here.
I'm
He's
here.
Yeah.
Thank you.
Okay. And of course, me and Professor Omar Youssef, we will be available all the session to assist you in moderating this session. Let me know, Bin, when you are ready. Bin, are you ready? Did you try
Yes.
share your
Yes.
everything? Okay?
I'm already ready. Yeah.
Okay.
We need to
because
check
we are
the slides, Dr. Nasser. We need to check the slides.
no need to check any slides. I think it's going to work because we are late. We have to start.
Okay.
Now it's 2:12. First of all, Professor Mahmoud Qurashi, please start the session.
Thank you very much, Nasser, Professor Nasser El-Ghandour, and Professor Omar Al-Hamad. It's a pleasure on behalf of CANS to welcome such renowned personalities to give us the webinar today. Thank you, Dr. Aaron Musara, for offering to moderate this session all the way from Zimbabwe. It will be exceedingly interesting to hear Professor Bing Su and Professor Shaddad to discuss the various options of management of brain aneurysms. So on behalf of all members of CANS and Member Society of the Continental Association of African Neurosurgical Societies, please proceed with your webinar. Thank you again, Professor Nasser and Professor Hamad.
Thank you. Thank you.
Thank you, Professor Mahmoud Khorashi, President of the Continental Association of African Neurosurgical Societies. Let me first introduce myself. My name is Nasser El-Ghandour, Professor of Neurosurgery, Cairo University, and the President of the Egyptian Society of Neurological Surgeons. It gives me great pleasure to welcome all of you in webinar number 11 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. As president of the ESNS and on behalf of all Egyptian neurosurgeons, I would like to express my sincere appreciation for the presence of Professor Bin Zhu. Professor Bin Zhu is well-known cerebrovascular neurosurgeon all over the world. I don't think he needs any introduction. Let me welcome our speaker, Professor Antar Shaddad. He is one of the eminent neurosurgeons in Egypt, specialized in cerebrovascular and endovascular neurosurgery. And Professor Aaron Musara from Zimbabwe. He is going to be the moderator of this session. Thanks to all of you for accepting our invitation and for contributing to this activity. For all our audience, thank you very much for attending and participating in this session. We are going to have live stream over the official group of the ESNS in the Facebook. The live stream of this webinar you can follow through the closed group of the ESNS, not through the YouTube, but it's going to be recorded and downloaded to the YouTube after the session. For all the audience, you can participate by chat questions, and the moderator will monitor this through the panel. Thank you very much. Now I will give the speech to Professor Aaron Musara to start the session.
Thank you, Professor Nasser El-Ghandour. It is my single honor and privilege to be a moderator for this session. I'm thankful to the Egyptian Society of Neurological Surgery and to the Continental African Association of Neurological Surgeons for this privilege. So I'll leave this time to Professor Bin Zhu to proceed and give us his presentation on the comparison of endovascular and microsurgical managements of brain aneurysms. Professor Zhu.
Okay, thank you, Chairman. And it's my great honor to attend this webinar. And hello, everybody.
Excuse me, Professor Bin Zhu. Excuse me 1 minute, please. I forgot that Professor Mohammed Helmi from Emirates, he is working with you in China, and he would like to give a short biography before you start your speech, please. Professor Mohammed Helmi, are you here?
Yeah, can you hear me clearly, sir?
Yes, please start to introduce for us. We welcome you, of course, in this activity. We are happy that you arranged with Professor Bin Zhu to make him our guest today. Please introduce him.
Thank you, Prof. Nasser, for giving me this chance. First, I'd like to introduce myself, as I may look unfamiliar to most of you. My name is Mohammed Helmi, originally from North Sinai, Egypt. Now I'm doing my neurosurgery master degree at Fudan University, Huashan Hospital in Shanghai. It's a great honor to introduce Professor Bin Zhu. He's a professor of neurosurgery at Fudan University, Huashan Hospital, honorary vice chairman of Yuha International Neurosurgery Center in Zhengzhou, China. He's a member of the Education, Ethics, Cerebrovascular Committee of World Federation of Neurological Societies. Regarding the educational background, Professor Bin Zhu had his MD, PhD at Fudan University in 2001. In 2002, he did postdoctoral research at UCSF in the United States. In 2007, he did interventional neuroradiology in Paris with Dr. Jacques Moret. To brief Professor Binshu surgical skills, he's a hybrid cerebrovascular neurosurgeon doing both open and endovascular surgeries. His annual interventional volume is about 100 to 150 cases. He's a world leader in surgical volume for Moyamoya disease with tremendous experience. And here I'd like to quote this sentence, which was said by Professor Michael Lawton. Binshu is the Barry Bonds of bypass surgery that nobody will be able to catch. And Barry Bonds, for those who are not interested in baseball, was an exceptional baseball hitter and considered to be one of the greatest baseball players of all time. Finally, I'd like to mention my impression about Professor Binshu from international master degree students' point of view. He's one of the best professors, teachers, and friends that a student, resident, or cerebrovascular fellow would have. Thank you for accepting the invitation, and please start sharing your screen.
Okay, thank you, Mohammed. So, dear colleagues, my topic is a comparison of endovascular and the microsurgical management for brain aneurysms. So I come from Huashan Neurosurgical Department. Last year, we have around 18,000 operations. We have 4 campuses, so maybe the largest neurosurgical department in the world. We have 800 beds and 14 operation rooms. And we are also the WFNS and the ACNS training center. So this is Mohammed. Maybe 3 years ago, I visited Nanchang when he is still in the university. That day, I have finished 10 cases in one day of bypass cases. So in my opinion, the endovascular treatment should be done by neurosurgeons because we know the anatomy. We see the aneurysms directly in the operation. And sometimes the aneurysm with the plaques, the dome maybe have some calcification and may have some daughter sacs, and there's some very small perforators. So we can treat the aneurysm not only from inner cavity of the aneurysm, but also from outside of it. We can do a lot of things immediately after disaster coming, clipping, bypass, or decompression, drainage. So we also use hybrid methods where we use combined endovascular with open surgery. So we can give the patient the treatment. So for the endovascular treatment, we have a lot of instruments. The guide catheter, we have a normal guide catheter. Also, we have a balloon catheters. So this kind of catheter can occlude the ICA temporarily. And the microcatheter and the guide catheter, coils, normal coils, hydro coils, or fiber coils, stent, we have 3 different kind of metal cover rate. Normal stent is around 8 to 10%. The Elvis stent, it's middle, it's around 18 to 20%. And we also have fluid diverters. The metal cover rate is around 28% to 35%. And we also can use balloon. Sometimes we use undetachable balloon, including hyperglide, hyperform, or scepter. And sometimes we also use detachable balloon. So we still use traditional clipping because it's save a lot of time and a lot of monies. So for the MCA aneurysm, it's shallow, so it's still the best treatment for the open surgery. Sometimes we can also use clip reconstruction because like this aneurysm, there's no neck and it's almost impossible to treat with stents So this is a final result. It's quite good. And this is a clip reconstruction. There's 2 domes. And if you use endovascular treatment, it's quite complicated. But if you use open surgery, it's quite simple. And sometimes we can both use shaping, clipping, and wrapping techniques, like this dissecting aneurysm with quite a long segment. This is a 3-dimension. You can see it's dissecting aneurysm of MCA. So this is what we can see under the microscope. So we can use the bipolar to shrink the dome of the aneurysm, and then clip it with fenestrated clips. And some remnant we can wrapping with a Dacron at M1 and M2. So sometimes we can also use hybrid treatment for M1 aneurysm. Like this patient, we can see the M1 segment, there's a lot of very important perforators around this segment. So I use a distal bypass combined aneurysm coiling, because there's no space to spare the LSA to direct clip it in the proximal part. So I use a hybrid treatment. You can see the final result is quite good. All the perforators around this M1 segment was all patent. This is a double bypass, was all patent, and the blood flow reflux to M2. And sometimes there's some recurrent after stent assist coiling. So we can still use clipping because of time limitation. I couldn't show this video. So this is different techniques of stent assisted coil embolization. So this is through the mesh of the stent, and this is through the mesh, and this is a gelling technique. And this is a so-called ice cream technique. We can specially used to the tip of the basilar artery. And this is a half deployment of the stent. And sometimes if the Bristol-like aneurysms, we can use a patch, like a patch blood Bristol-like like a cat of the, we can see this is like a patch of the vessel wall to cover the Bristol-like aneurysm. Sometimes this is a kink technique. We can support the coils around the bifurcation aneurysm. And sometimes we can also use transverse stenting for the basilar tip aneurysms. For the wide neck. And for the bifurcation located aneurysms, we can also use Y shape or parallel Y shape, side by side Y. And for the basilar trunk aneurysms, we can use double layered stent. And sometimes we can also use side by side double stent. And for the very wide neck ACAM aneurysm, normally we can use X-shape stenting technique. And sometimes we also can use double catheter technique to use a catheter to support the coils. This is a case examples. This is a ACAM aneurysm. It's a very ugly shape. There's some daughter sac to the dome. And this is a final result. We can see with the stent assist coiling, the aneurysm was treated perfectly. This is the final result. And this is a ruptured vertebral dissecting aneurysm. We can see the proximal stenosis, and we can see the double lumen sign of the dissecting aneurysm. So this is a very good candidate for the stent assist coiling. So this is the final result. It's this kind of aneurysm, it was very difficult to treat with open surgery. So this is a basilar tip aneurysm. It's also a ruptured one. You can see this with stent assist coiling, we treat the aneurysm perfectly. And this is also a basilar tip to PCA aneurysm. Almost most neck was at the PCA P1 segment. So we use a stent assist coiling and treat the aneurysm perfectly. And we can see all the perforators around this segment was all patent. And this is a very small microaneurysm at the ICA. And this is a ruptured one. We can see the with a stent assist coiling, we treated the aneurysm perfectly. So this is very easy comparing to clip. So this is the final result. And this is a P1 to P2 aneurysm. This is also a very good candidate for the interventional treatment. You can see the it's a proximal stenosis, then enlarged. Actually, this is also a dissecting aneurysm. So with the stent assist coiling, we can get a very good result. So this is also vertebral dissecting aneurysm. So this is we can see the proximal stenosis and see the double lumen of the aneurysm. So this is definitely the good candidate for interventional treatment. So for this patient, we use double layered stenting. So we don't put the coil because there's original part of the pica was come from this aneurysm. Sometimes this is a very thin and flat ruptured aneurysm. We can see this is a ruptured aneurysm. There's subarachnoid hemorrhage, and we can see the DSA. This is a very small aneurysm. It's very flat and wide neck. So this is a final result. We can see the with the stent assist coiling, it's treated perfectly. So for the periclinoidal aneurysm, like this patient, this is two aneurysms on both sides of the ICA. So we also use stent assist coiling, and the two small aneurysms was treated perfectly. So this is a ICA Bristol-like aneurysm. We can see this is the aneurysm is a ruptured one. We also use a stent assist coiling. And this is the final result, and this is a long-term follow-up. It's cured. So we have different options at the different locations of the aneurysm. For the cavernous segment aneurysms, this kind of aneurysm, if it's a ruptured, normally it causes CCF, but not subarachnoid hemorrhage. So this segment, we can use a covered stent or detachable balloon or coils plus onyx. If it's an unruptured one, if it's asymptomatic we can normally follow up for this kind of aneurysm. If it's a symptomatic big or giant aneurysms, we can use covered stent or fluid diverters or coils plus stents. We also can use the bypass combined with a proximal occlusion of ICA. So like this very giant cavernous segment aneurysm. Because balloon occlusion test was quite good, so we can occlude the ICA directly. For the paracronoidal aneurysms, if it's a blister-like aneurysms, if it's a ruptured one, we can use stent plus coiling. But this kind of technique still have a high rate, highly ruptured rate. So open surgery is better. For the unruptured one, we can use fluid diverter combined coils. If it's multiple aneurysms, we can use fluid diverters plus coils. If it's small or middle size, we can use LD stent combined with coils. If it's a big or giant aneurysm, we can use fluid diverters. Sometimes we can also use hybrid treatment. We can use balloon catheter proximal occlusion, and then suction, then decrease the pressure of the dome. Then we can clip it directly. Sometimes we can also use the bypass, combine the proximal occlusion of ICA with coils. So stent should be cautioned in emergent stage. Balloon assist technique is very useful in treating the intraoperative ruptured cases. So this is a recurrent after clipping. We can see this is a ophthalmic segment aneurysm. After clipping 3 years later, it's a recurrent. So we use stent assist coiling and get a very good result. For the PCAM to ICA bifurcation segment, if it's a small or middle size, if it's a ruptured one, we can use coils or balloon plus coils in acute stage. If it's an unruptured one, we can use coils or stent assist coils. If it's a big or giant, we can use fluid diverters plus coils. Sometimes we can also use a hybrid treatment, balloon catheter proximal occlusion and the suction combined clipping. Or we use bypass, combined proximal occlusion of ICA with coils. Like this PCAM aneurysm is a ruptured one. We can see the aneurysm come from the PCAM original part of the PCAM. So this is a very easy case for interventional treatment. So this is also a PCAM aneurysm. We can see with the stent assist coiling, we still keep the original part of the PCAM, but thrombose aneurysm. So this is also a PCAM aneurysm. We can see some plaques in the proximal part, but this is a very good result. For the A1 to ACAM or A2 segment aneurysm, we can use coils, or sometimes we use stent assist coils. If it's ACAM, very wide neck aneurysm, we can use X or Y-shaped stenting. Sometimes we can also use small size fluid diverters for the A2 or even distal wide neck aneurysms. If it's a giant ACAM aneurysm, may need hybrid treatment. Like this patient, this is a very ugly shape, a very wide neck, and you can see actually there's no regular shape of the neck. This is a giant ACAM aneurysm. So when I try to clip it directly, it's impossible. So I use 2 fenestrated clips to separate the very wide dome into 3 parts. Then I treat the 3 parts with coils separately. So this is a final result. We can see the 2 fenestrated clips make the dome into 3 parts. Then every part was treated with the coils. This is the final result. We already followed the patient for 2 years. It's all stable. For the MCA aneurysm, normally it's still the good candidate for open surgery. But for small size or regular shape, we can still use coils or some stent assist coils. For the big or giant M1, M2 superior trunk aneurysm with important perforators, or sometimes with a partial thrombus or calcification, we can use fluid diverters. Like this is M1. This M1 actually is enlarged, but this is a ruptured segment. So we only treated this ruptured dome with coils, assist coils with stents. And sometimes this is a recurrent part of the MCA aneurysm. So the second treatment, we use stents, assist coiling. For the vertebral or basilar artery or PCA, PICA, proximal segment, all can be treated by coils and stenting. And stenting is easy. Some PICA aneurysm, especially the distal one, clipping is better. In some giant fusiform basilar artery aneurysms, fluid diverter is the only treatment. This is a special basilar tip aneurysm with moya. We can see this is a very ugly shaped aneurysm. And after to treat the bilateral moya disease, then we treat the basilar tip aneurysm with a stent assist coiling. And this is the original part of the PICA, and this is the vertebral artery aneurysm, dissecting one. So we use stent assist coiling. So most of the posterior circulation aneurysms we can treat with embolization. So this is a very small, very giant aneurysm of P1 to P2 segment. So we only put some proximal coils at the P1 segment. Then the aneurysm was shrinked. And the final result is quite good. So this is a vertebral aneurysm, basilar trunk aneurysm, and fluid diverters. Now we have more and more fluid diverters, pipeline, silk, stent, and this fluid surpass. And in China, we also have tube bridge. So this is a tube bridge. We can see the final result is very good. This is a tube bridge. So this is a hemodynamic change after the fluid diverters. We can see the energy was decreased a lot in the in the aneurysm dome. So it can make the aneurysm thrombus. The fluid diverters is both safe and effective with a complete occlusion rate of approximately 75%, and the morbidity and the mortality rate is quite low. So this is my colleague, Professor Donglei Song's cases. We can see this is a Bristol-like aneurysm at the ICA segment. We can see just after the pipeline implantation, then we can see the stagnation of the contrast in the aneurysm. So this is all pipeline case. So you can see all the result is very good. Actually, this kind of patient, if you use open surgery, is very complicated and it's easy to recurrent. So from around 6 years, there's 136 patients and 150 aneurysms. We can see the result is quite good. This is a pipeline, 78 cases. This is a 6 months follow-up. 68 was cured. And for the long term, even more long term, there's 8 additional cured. And another 11 cases was shrinked. But the pipeline also have some complications. There are some small infections without symptom in 10 cases. ICA choroidal occlusion without symptom in 1 case. And the subarachnoid hemorrhage at the same day of treatment in 2 cases, 1 died. Intracranial hemorrhage, 4 cases, small without secondary in 2 cases. 1 died of big hemorrhage to 7 days. 1 has hemiparalysis after craniotomy. So this is an example. This is a male patient, boy, M1, very large M1 aneurysm. We can see there's some a lot of very important perforators to the dome of the aneurysm. So we treated with pipeline. So this is a pipeline implantation. It's quite good. And this is immediate result is quite good. But the second day, there's some hemorrhage. And then remove the hematoma and the decompression. And the final result is quite good. But the patient got some neurological deficit. So now I will talk some bypass treatment for the giant and the complex aneurysms. So bypass for giant ICA aneurysm, this is a blood flow replacement technique. So this is our strategy for ICA aneurysm. Before the treatment, we will use balloon occlusion test. Normally, we will perform 30 minutes. If it's negative, we will use enhanced balloon occlusion test, which means the blood pressure decreased to 30%. If it's still negative, this kind of ICA can be occluded directly. If it's positive, so this kind of patient need STA to MCA double bypass. So if the balloon occlusion test was positive, we should make the plan of blood flow replacement. If the ICA feeded the MCA territory, we can use, if the patient is male, we can use the double bypass of STA to MCA. If the ICA feeded not only the MCA territory, but also the ACA. So this kind of patient, we should use the ECA to radial artery to MCA, plus STA MCA bypass. If it's not only feeded the same side of the hemisphere, but also the contralateral ACA territory. So this kind of patient, we should use the saphenous vein to MCA. This is a high flow bypass. So this is our strategy. We can see from no bypass to STA bypass to radial artery bypass, or STA to, combined with radial artery or saphenous vein. Like this ICA proximal joint aneurysm, we can see this is he suffered sudden right hemiplegia for 3 months. So this is a giant ICA aneurysm. They tried to use fluid diverter, but it's failed. So I use bypass technique to use the double bypass of STA to MCA. So this is after the double bypass, we can see this is the ICG. We can see the blood flow was all patent. Then we use STA, the proximal clip. This is a temporary clip. So I designed this clip, this progressive clip. So at the first stage, we clipped it, occluded around 70% of the ICA. Then in the 6 days, we were totally occluded the ICA. So after 6 days, we totally occluded the ICA. Then we follow up the DSA. We can see the double bypass was all patent. So then the aneurysm was cured. So there's some collateral blood flow from ACAM and PCAM. So this is a type 2 ICA aneurysm, no collateral blood flow from ACAM and PCAM. So the blood flow replacement should cover MCA to ACA territory. So balloon occlusion test was positive. So I use saphenous vein. This is a high flow bypass. We can see the blood flow covered the whole hemisphere. So this is type 3 ICA aneurysm, poor collateral ACAM and PCAM. But the blood flow, the A1 still have some feeded to this side, MCA territory. So the blood flow replacement should cover the left MCA territory. This is a female patient. The STA was quite small, so we still need the radial artery to MCA. So this is a radial artery bypass. So this is the final result. We can see that radial artery bypass was all patent and covered the whole MCA territory. So this is a MCA, radial artery to MCA bypass. So this is a proximal ECA to radial artery bypass. So this is a ICA aneurysm with a good ACAM and poor PCAM. Balloon occlusion test, 20 minutes is negative, 30 minutes is positive. So this kind of patient need blood flow replacement should cover the partial MCA territory. So I still use the STA to MCA double bypass, combine the ICA proximal progressive occlusion. So this is another kind of traditional progressive clips. So at the first stage, we also narrowing around the 70%, then totally occluded in the next week. So we can see the double bypass was all patent, and then we sacrifice the ICA. This is a type 5 ICA aneurysm with a cavernous sinus syndrome. Bone occlusion test, CT perfusion was good, but enhanced BOT was positive. So this kind of patient only need partial MCA territory blood flow replacement. So this patient only need the STA MCA double bypass combined with ICA coiling directly. We can see the double bypass was all patent, and the ICA was occluded with coils immediately. So then we can treat the even distal MCA aneurysms because the giant and the complex MCA aneurysm was very common in our department. So bypass combined proximal direct occlusion of MCA. Sometimes we will use distal occlusion of MCA, and sometimes we combine with trapping of MCA aneurysm. So the purpose is decrease the pressure of the aneurysm wall and keep the blood flow in perforators, keep the blood flow of distal parent artery, and sometimes we also use protective bypass. So then we can get more time to of temporal clipping. Like this is a MEP SEP monitoring in route. MEP SEP was prepared in every cases, and we use ICG Flow 800. It's also very helpful in selection of the recipient artery. Sometimes we use a hybrid operating room in the this is the best choice. So this is the MCA aneurysm straightedge we published 2 years ago. So my personal principle is to make the surgical plan as simple as possible, the bypass time as fast as possible, and the number of the stomas as few as possible. So the technique knows replace enough blood flow for MCA territory or partial replacement. For male patient, normally 2 STA branch are enough. For female patient, STA branch may need a radial artery. One STA branch can create double barrel bypass to increase the donor flow. So this is a male patient. Normally 2 STA branch are enough for replace the whole MCA territory. You can see the double STA MCA bypass can cover the whole MCA territory. So sometimes we also can use single branch of STA to create the double barrel bypass. For distal ICA M1, this is the blood flow replacement should cover the whole MCA territory. So with the help of SCP MEP, we treated the aneurysm dome perfectly, and this is another case of M1 segment. We can see we trapped the aneurysm and use a radial artery to replace the distal part of the MCA territory. So this is a type 2 unruptured M1 aneurysm with thick wall. this kind of patient, we can use distal occlusion combined with this distal bypass. The blood flow reflection cover 2 M2 segments. So this is a stomach. Just after 1 week, we can see the aneurysm disappeared. Or even distal M2 MCA superior trunk aneurysm. We can see this is a protective STA to M3 bypass. Combined clipping of the aneurysm, we can see the this is a protective bypass with it's a patent, and actually the aneurysm cavity was treated perfectly. We can see the basal the basal wall was treated perfectly. This is a type 4 aneurysm resection and in situ anastomos of M2 segment. So this is an aneurysm. We can see it's a tortured vessel, so we still have the enough length to do the in situ anastomos. So this is the final result. For the superior trunk, we can also use proximal clipping combined distal bypass. We can see this, we only use proximal 1 clip and the distal bypass. This is even distal one. We can see it's a giant aneurysm. The aneurysm was partially thrombosed. We can see it's a very good, big one. We only use distal STA to M3 bypass combined with a distal clip of the aneurysm. Sometimes we also can use hybrid treatment. I already introduced this case. So now I will introduce a new graft artery in the patient with a short radial artery. If the patient is short, normally the radial artery was quite short. So we can use a right GEA. This kind of artery is longer than the radial artery. So normally it can harvest around 25% centimeter. This is enough for the ECA to MCA bypass. So this is a final result. We can see the bypass was all patent, and this is a RGEA and the STA. The double bypass was all patent, and then the radial artery, the aneurysm was disappeared. So this is my take-home message. Neurosurgeons should know the advantages of interventional treatment. The hybrid neurosurgeon can give the best treatment for different aneurysms. Giant or complex aneurysms still need bypass, and we can create a new hybrid treatment for complex aneurysms, like I already introduced. Thank you for your attention. So because after this webinar, I have another one, so I'm sorry I couldn't attend the discussion.
Okay.
Okay.
Thank you, Professor Xu, for the wonderful presentation. Are you prepared to take 1 or 2 questions?
Okay, no problem.
Yeah. Maybe we could hear from participants if there's anybody. I'm waiting for any raise of hand for anybody who may want to ask a question.
Dr. Musara, may I ask a question?
Yes, please. Go ahead, Prof. Omar.
Yes, thank you, Dr. Chu, for joining us in this webinar, and thank you for this nice illustrated work and presentation. My questions, what's your tips and tricks for the large paraclinoid aneurysm?
Oh, for this kind of paraclinoid giant aneurysm, now more and more often we use fluid diverters. And we can I also introduce some techniques with long occlusion, proximal occlusion. Then we will suction of the vessel, the aneurysm dome, and then the pressure of the aneurysm was decreased a lot. Then we can clip the aneurysm very easily. So this is for surgical treatment. We use a balloon catheter, guide catheter, to achieve the proximal occlusion of ICA. Then suction of the catheter, then the very giant aneurysm, the pressure was decreased a lot. Then we can clip it very easily.
Thanks.
Okay.
Thank you.
Thank you.
All right. Considering that Professor Chu has got another presentation to make, maybe we will proceed to the next speaker, Professor Mohammed Shaddad from Itanta University in Egypt.
Good afternoon, Professor Misra. I am Mohammed Shaddad, Professor of Neurosurgery and Director of Neuroendovascular Section, Department of Neurosurgery, Tanta University. And I am the Assistant Secretary of Egyptian Society of Neurological Surgery. Thank you, Professor El-Ghandour, for giving me this chance to share my experience with all of dear guests and dear attendees. Today we will speak about important topic, especially in overpopulated countries like Egypt and China, where there is a lot of road traffic accident. Our topic today is direct carotid cavernous fistula. Transarterial embolization of direct carotid cavernous fistula by coils. Anatomical hint about the topic. Cavernous sinus is one of the paired intracranial venous channels between endosteal and meningeal layers of the dura mater. It is all intracranial venous sinuses are valvulus, allow bidirectional flow of blood. Cavernous sinus located in the paracellular region with on either side of the sella turcica of sphenoid bone. Only one of paired sinus communicate with each other through anterior and intercavernous connection. Cavernous sinus is conduit for venous blood and allow passage of the cranial nerve 3, 4, ophthalmic and maxillary division of trigeminal nerve and abducent nerve, as well as cavernous portion of the internal carotid artery. It receives blood from sphenoparietal sinuses, superior and inferior ophthalmic veins, superior and inferior ophthalmic veins, and efferent hypophyseal veins. Drain through superior petrosal sinus to sigmoid sinus, inferior petrosal sinus to jugular bulb, and venous plexus on internal carotid artery and to basilar venous plexus. Definition of type A: abnormally high flow arteriovenous communication. Abnormal high flow arteriovenous communication between internal carotid artery and the cavernous sinus, usually resulting from direct tear in the carotid wall. Subtypes include 3 subtypes. High flow, all blood from the internal carotid artery entered the fistula without filling of intracranial vessels. Intermediate flow, both of the fistula and intracranial vessel received the blood from ICA. Low flow subtype, only slow and sluggish filling of the cavernous sinus was apparent. Pathophysiology: increased venous pressure of cavernous sinus, which transmitted to anterior to ophthalmic vein, posterior to inferior petrosal sinus, and sometimes to cortical veins, and this is the most dangerous. Clinical presentation: classic triad of exophthalmos, chemosis, and Perui due to increased orbital venous pressure, diplopia due to irritation of the 3rd, 4th, and 6th intracranial nerves. Visual loss is the most dangerous due to retinal ischemia. Epistaxis and intracranial hemorrhage due to increase in the venous pressure are the least common and most dangerous. Radiological evaluation: CT brain with bone window in different planes and 3D reconstruction shows basal skull fracture and intracranial hematoma. CT angiography sometimes is a good asset in description of the fistula. MRI and MRA could provide important information like dilatation of the superior ophthalmic vein. Cerebral angiography is still the gold standard in diagnosis, classification, and the planning of treatment in direct carotid cavernous fistula. Using a high frame rate, 7 frames per second, its lateral internal carotid examined with trial for localization of the site of the fistula and determination of the venous outflow. Testing contralateral internal carotid artery and vertebral artery to check presence of good collaterals if carotid occlusion is planned. Treatment option: revolution in the endovascular treatment of carotid cavernous fistula started with introduction of detachable balloon by Serbinianko in 1974. Recent advances in endovascular techniques achieved with refinement of microcaster, microwires, balloon, and coils, in addition to improvement of the image quality with aid of new generation of angiography machines. To date, endovascular technique became the state of art in carotid cavernous fistula management. Type A carotid cavernous fistula are less likely to resolve spontaneously and usually mandate endovascular intervention. Different endovascular technique, including transarterial, transvenous, either retrograde or superior ophthalmic vein puncture, direct with occlusion of the fistula site and keeping patency of the internal carotid artery. When failed, occlusion of the carotid with fistula site in the presence of good collateral is an option. This study report and validate efficacy and safety of transarterial embolization of direct high flu carotid cavernous fistula by coils instead of balloons as primary modality of treatment. Between December 2010 and December 2016, total of 12 patients, 10 males and 2 females with direct carotid cavernous fistula were treated by endovascular transarterial approach by coils. Follow-up was done at least for 6 months. Cases presentation. Our first case, female patient, 65 years old, motor vehicle accident in Saudi Arabia, presented with left side proptosis, left intermediate flu, direct carotid cavernous fistula, successful balloon test occlusion and good collateral supply, total obliteration with coils with left ICE preservation. This is the ipsilateral internal carotid artery in lateral and AB view, showing the fistula, intermediate flu, blood come to the ophthalmic veins and intracranial vessels. So this is intermediate flu, draining anteriorly through the common facial vein. Balloon test occlusion showing good collateral, good anterior half of the circle with good A1 on both sides, transmitting the blood to the side of the fistula, and good BCOM with good filling of the ophthalmic artery. Venous phase of balloon test occlusion. There should be or must be no lag more than 4 seconds between both hemisphere veins. Sometimes I do balloon test occlusion, and I depend mainly on this point: simultaneous appearance of the cortical veins on both hemispheres with no lag more than 4 seconds between both hemispheres. And this is the coil mass at the fistula site. This is the final control, preservation of the internal carotid artery in lateral and AB view. And this is the pre and post images of the patient eye after 1 month. This is pre and this is post. Case number 2, female patient, 30 years old, falling from height, presented with right side proptosis. BSA revealed right intermediate flu, direct carotid cavernous fistula. Failed balloon occlusion test with poor collateral blood supply, which mandate total obliteration of the fistula with coils, but with carotid right internal carotid preservation is a must. There is no good collateral. And this is the DSA at the start in lateral and the AB view, showing the fistula site, drained anteriorly to superior ophthalmic vein, inferior ophthalmic vein, and posteriorly to the inferior petrosal sinus and superior petrosal sinus, here and here. And this is the balloon test occlusion, failed, no collateral supply due to hypoplastic A1 segment on the right side and also from BCOM. This is the balloon test occlusion. Venous phase, there is lag of veins on both hemispheres, more than 4 seconds. Veins on the right side not appear simultaneous with the veins on the left side. Control at the end. with obliteration of the fistula and the preservation of the right ICA. Now, total obliteration of the fistula achieved. And this is simultaneous control from both internal carotid artery. Now, intracranial circulation is established after obliteration of the fistula. Veins now come together, but this is injection from both sides at the same time. And this is the pre and post after 1 month image of the patient. This is the proptosis, and this is after 1 month. So in the previous 2 cases, we preserve the carotid and we just did obliteration of the fistula. Case number 3, male patient, 20 years, student in our university, after motor vehicle accident, presented with right side proptosis and right visual loss. Right side DSA show right side high flow, high pressure cavernous fistula with extensive right internal carotid tear and cortical venous reflux with high risk of bleeding. Successful balloon test occlusion and good collateral supply. We did isolation of the fistula at the start, then followed by total obliteration of the carotid cavernous fistula in addition to the right ICA. This is the MRI showing dilatation of the venous spaces, showing dilatation of the superior ophthalmic vein. This is the site of the fistula with dilated venous spaces on the right side. And this is the digital subtraction angiography at the start. Here there is marked cortical venous reflux. This is very dangerous as it could induce hemorrhage. Marked dilatation of the venous spaces, marked reflux to the cortical veins, extensive tear of the carotid artery. I inject this with a balloon occlusion test. There is steal of the blood to the cavernous sinus. With this steal, it is very dangerous, and I decided first to isolate the fistula from the intracranial circulation, because I feared that if there is any small remnant could drive the whole brain blood to the fistula side, and with this steal the patient will suffer from global ischemia. So I started with obliteration of the occlusion of the carotid distal to the site of the fistula. This is the venous phase of the balloon occlusion test. Simultaneous appearance of veins on both hemispheres. And this is the first step of, in our case, I occluded distal to the fistula, changing it to just fistula between the internal carotid artery and the cavernous sinus. I totally isolate the intracranial circulation with this good collateral. Then I continue by occlusion of the fistula and occlusion of the internal carotid artery. This is the controlled DSC after obliteration of the fistula, right ICA occlusion with excellent collateral circulation from ACOM and BCOM. And this is the control from ipsilateral carotid artery. And this is the coil mass in the cavernous sinus, in the internal carotid artery, distal and proximal to the fistula. And this is the pre and post images of the patient after 1 month. This is the pre, this is the post. Case number 4, male patient, 14 years old, motorbike accident, presented with left side proptosis, left high flow, direct carotid cavernous fistula, successful balloon occlusion test, and good collateral blood supply. Total obliteration of the left carotid cavernous fistula with ICA occlusion. This is the DSA at the beginning, from ipsilateral and contralateral side in lateral and AB view. And this is the balloon test occlusion with simultaneous veins on both hemispheres. Good cross filling to the other side. And this is the different stages of coiling without progressive stages in the superior ophthalmic vein. Finally, the carotid with this extensive tear I have to occlude. And this is the control at the end with good filling of the ophthalmic artery. This is very good point. You should check the filling with your balloon occlusion test. You should check the filling of the ophthalmic artery. Because sometimes the flow is opposing. This come from the BCOM and fill the ophthalmic artery. If the flow of this come up and flow from the supraclinoid carotid come down, so is opposing flow lead to stasis of the ophthalmic artery, and sometimes you get the patient blind after operation. So you should check good filling of the ophthalmic artery, and you should avoid this functional stasis. This is the pre and post-operative images of the patient after 1 month and after 1 year. This is after 1 month and this is after 1 year. And this is the follow-up MRA after 1 year. Our results: complete obliteration of the fistula was achieved in 12 patients, 100%. 1 patient has partial recanalization during the period of follow-up and needed second session to add more coils. No treatment-related morbidity or mortality achieved in our series. Coil embolization is an effective and safe alternative to balloons for treatment of direct high-flow carotid cavernous fistula. Advantages of coils including easy access, control, adjustment, deployment, retrieval, reposition, and availability to different thickness, sizes, lengths, and shapes. Allow more techniques to deal with such fistula. Thank you very much. Thank you, Professor El-Ghandour. Thank you, Professor Benzo, and thank you, Professor Mesra.
Thank you, Professor Shaddad. That was quite a good presentation. I've enjoyed it. Seeing trauma is with us for a long time, especially here in Africa, looking at our happy epidemiology of trauma. I'm sure this is a very relevant topic for us. So we would like to take some questions at this moment.
Yes.
Yeah, there's I think a comment here from Hitama Hassan says, I do advise you to use balloons and onyx after coils. This will help you to preserve more carotids unless the TA is complete. What's your comment to this one?
Sometimes we use balloon, but we present this is our experience regard some cases we did with coils only, and we find it very effective, and you have better control because with this balloon sometimes deflation, migration, and you have a lot of troubles.
Can I ask a question, please? Mr. Arun Masara?
Yes.
Yes, this is Usama Al-Ghannam. There is, you know, we are the old school people. Sometimes, and probably Professor Qureshi knows that, in Southampton, Jason Bryce, he's a great surgeon there, and used to say traumatic carotid cavernous fistula, you can wait because sometimes there is spontaneous resolution. They are cured by themselves. So did you really wait for some time? Because the vision is lost already in your case. So you're not losing anything if you wait something because they have a spontaneous cure. And we're talking only this is for traumatic, but not for the spontaneous due to ruptured intracavernous aneurysms. Have you got any comment on that, please? Thank you.
Yes, Professor Shadat, you can go ahead and answer.
Please again the question because I have difficult in internet last moment.
Okay.
Well, my comment is there are some surgeons, they say traumatic carotid-cavernous fistula, they sometimes resolve and cured spontaneously just by time, and they don't do anything for it. Of course, this is different from spontaneous carotid-cavernous fistula due to ruptured intracavernous aneurysms. So how long do you wait any time after the discovering or diagnosis of traumatic fistula, or you just treat it once you diagnose? Because if the patient is already blind, so are not losing anything if you wait some time. So,
thank you, Professor Osama, for this question. First, not all patients come blind. Some patients come with viable vision, and leaving them for more time create a problem, like increase the intraocular pressure, predispose to glaucoma and visual loss due to increase the venous pressure. In addition, the patient may develop cortical venous reflux, and this is very dangerous, like the case we present. So with these big tears in the carotid, these extensive carotid tears, I don't think there is any way to heal without intervention. So we prefer going very early once diagnosed, because this venous space dilate more and more, create more venous reflux, either through the ophthalmic vein or either through the cortical veins, and this is very dangerous as it predisposes to bleeding. So once diagnosis, we should interfere. This is as regard this direct high flow, high pressure post-traumatic carotid cavernous fistula. But sometimes with type B or C or D, with this indirect fistula, sometimes it heals spontaneously, sometimes it heals with just cross carotid compression with the patient other hand contralateral to the fistula, press the carotid for like 5 minutes every day for 3 to 4 times, and this for 1 month. sometimes these small indirect connections, either from the external carotid or either from cavernous branches of the internal carotid artery, sometimes spontaneous thrombosis occur.
Okay,
But for this
that's good.
direct traumatic fistula, I don't think so.
Okay, that's good. Thank you. So it tells that there's conservative treatment, even if it's a minor cases there. Thank you very much, Dr. Mohammed.
Thank you, Professor Hussein. Thank you.
Okay. I would like to ask Tama Essen to go ahead and ask his question on
Yes.
hip balloons.
Yeah. Hello, everybody.
Hello.
Hello, Professor.
Well, first I have to congratulate Dr. Shaddad for his excellent work. Second thing is I noticed that if the fistula is small, you succeeded with coils without protective balloons. But if the fistula is big, you tend to occlude the artery. Well, I have an advice, because we have experience of a lot of those patients of traumatic carotid cavernous fistulas in our department. We use a very long balloon, and if we cross the artery, then the tear is not complete. If you can cross, as your third case that you started occlusion from distal to proximal, then put a long balloon, and then put some coils, and then start to inject onyx under carotid artery occluded, with the carotid artery occluded. If you inject the onyx will go everywhere. It will go to the sylvian vein and occlude it to prevent the cortical venous reflux. It will go to the SOV, it will go to the IPS, it will go to the SPS. So you don't have to follow all those places to put coils in there. And you will save a lot of coils putting there and a lot of time during the radiological exposure. So if you put some coils through the transarterial route, and then you put a long balloon in the carotid artery, you can, and then inject onyx. After you fill all the sinus with onyx, wait some time, and then deflate the balloon, and then you will find your carotid artery safe, and then the fistula is all gone. Try this technique, it will save more coils and save more time, and you can preserve more carotids with it. Finally, congratulations for your excellent work. About the fistulas, direct and indirect, you can wait for the, about comment of Professor El-Ghandour, we can wait for the indirect fistulas if it's dural. But if it's direct fistula, the more you wait, the more it will grow, and the veins are going to grow more and more. So it's better to treat early. Thank you very much.
Thank you.
Thank you, Professor Hassan. I agree with you. We can use alternative techniques, but in this study, we use coils for these cases. But I agree with you. Sometimes I use these balloons and onyx, and but I feel coils more comfortable with this.
Onyx after coils, not onyx alone. Onyx after coils is very good technique. Please try it.
Yes.
Okay, thank you.
Thank you, sir.
Now, just another question. You have been mentioning mainly the use of coils. I didn't hear much about the use of stents together with coils. What's your opinion in terms of using stents and coils at the same time for the carotid or cavernous fistula?
I never used it, but in some centers worldwide they use it. They use this stent-assisted coiling, so they use stent in addition to coils. But with this extensive carotid tears in the cases we present, I don't think it will work.
Okay.
Well, I have a little comment on this, Dr. Musra, about the use of stents. So before we use the onyx, we tend to fill the fistulas with coils, but sometimes the results are not complete. So we used covered stents, covered cardiac stents. And then we navigate the covered cardiac stent until the tear, because you can understand the tear after you put some coils. The flow is getting slower. And then after you inflate the covered stents, you can get a complete separation from the fistula. So the use of covered stents, we tried few times, but it's also reported in the literature.
Okay, thank you. It looks like there are no more questions. Left to thank you, Professor Ichadat, for this wonderful presentation. As I hand over back to Professor Nasser El-Ghandour.
Thank you, Professor Musara, for moderating this session. It was a great session. I would like to thank our speakers and all my colleagues who contributed to this webinar. I'd like to thank Professor Osama Al-Ghannam, Professor Omar Youssef, Professor Muhammad Shaddad, Professor Tamer Hassan. I'd like to thank the organizers of this webinar. Let me announce about next week. It will be about hydrocephalus. We will have Samer El-Baba from United States and Professor Mahmoud Qurashi from Kenya, resident of Kansas. And the moderator will be Professor Muhammad El-Biltagi. Thanks to all of you for this great session.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Musara, and thank you, Dr. Qureshi and Dr. Chu. Thanks, Dr. Nasser.